Okay, so we're gonna start in about like a minute. So just for you know. Oh well, I sent to you another email. The first one was wrong, but the second one you can write me wherever
Yeah.
where
You
you
sent an email to me right now, yes?
sorry.
You sent me an email right now.
Yeah.
Okay, okay. I'll check it out.
All right. Well, the transmission is almost ready.
Hmm. I don't believe I received the email. Maybe it will take some time to arrive.
I think that we're gonna start in any second. So
Okay.
just let me see. Mm, mm. Right. So we are already on Facebook. So bueno, muy buenos días a todas las personas que nos comienzan a sintonizar. Hoy para la primera ponencia del día de hoy. Me es muy grato continuar con el programa. Y bueno, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, chairman del World Congress of Neurosurgery, de la UNESCO ASPNet Walter E. Dandy, in honor to Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, chairman del capítulo ANSI-PN, al doctor Salim Abdurrahman, chairman de Walter E. Dandy Neurosurgical Society, al doctor Babak Kateb, chairman de la Society for Brain Mapping and Therapeutics y de la Brain Mapping Foundation, todos ellos vice chairmans del comité organizador, y al doctor Parménides Guadarrama Ortiz, chairman del Centro Especializado de Neurociencias y Neurocirugía en México. Es un honor para mí, sorry about that, es un honor para mí presentarles a la primera ponencia del día de hoy, desórdenes y agentes que afectan nuestros sueños, que será expuesta por el doctor Ahmad Assassa de Rumania, miembro perteneciente a la Romanian Association of Neuroscience, and a student at the University of Medicine and Pharmacy, Carol Davila de Bucharest, Romania.
Thank you very much, Dr. Louis Gonzalez. Good morning, good afternoon, and good evening, wherever you may be. I'm Dr. Christopher Burton, and it is my pleasure to open today's presentation. I would like to welcome you to the third week of the World Congress of Neurosurgery, UNESCO, the Walter E. Dandy Society, in honor of Professor Gazi Yaşargil. On behalf of the Ambassador of UNESCO, ASPNet, Jorge Herrera Ramos, President of the World Congress, whom we thank for organizing this event, as well as the Vice Presidents, Dr. Deyanira Capi, President of the AANS IPN chapter. Also, Dr. Salim Abdelraouf, President of the Walter E. Dandy Neurosurgical Society, Dr. Babak Kateb, President of the Society for Brain Mapping Therapeutics, Brain Mapping Foundation, as well as the Honorary Chairman of the Committee, Professor Nasser Al-Gandur, Professor Marcus Rota, and also to Dr. Parmenides Guadarrama, Director of the Specialized Center for Neurosurgery and Neurosciences of Mexico. It is an honor to introduce today's speaker, Dr. Ahmad Assassa, who will present disorders and agents that affect our sleep and dreams. Whenever you're ready, you may share the screen and start when you're ready.
All right, thank you for the introduction. Let me see if I can. Can you see my screen? Is
Yes,
everything
I
okay?
can. Yes.
Okay.
Everything's good.
So before I start, I would like to, first of all, thank Dr. Jorge Herrera, Dr. Salim Abdulrauf, and Dr. Baba Kateb for organizing this event and being such wonderful hosts. Today, I will be presenting about disorders and agents that affect our sleep and our dreams. So there are four main stages when it comes to sleeping. I will be focused more on stage 4 and factors that affect the stage. But before that, I want to talk a bit about the first 3 stages. I'm sure, as you all know, these initial stages can be classified as the non-REM stage, while the 4th stage is the REM stage. Stage 1 is essentially the dozing off stage. I think everyone's familiar with this one. After a long day at work and you feel your eyes slowly close as soon as your head hits the pillow. The stage typically lasts 1 to 5 minutes. During this stage, the body hasn't fully relaxed. The body and brain activity start to slow with occasional twitches. It's very easy to wake someone up during this stage. Stage 2 is when the body enters a more subdued state, including a drop in temperature, relaxed muscles, slowed breathing, and heart rate. Eye movement also stops. Brain activity slows, but there are short bursts that help resist being awoken by an external stimuli. While stage 2 can last from 10 to 25 minutes, a person typically spends half of their sleep in this stage. Stage 3 is also known as deep sleep. It's harder to wake someone up in this phase. Muscles, pulse, and breathing rate decrease even further in stage 3 as the body relaxes more. The brain activity during this period has an identifiable pattern of delta waves. As you can see, this is an electroencephalogram, EEG, of a patient during slow wave sleep, or stage 3. High amplitude EEG delta waves is highlighted in red. This stage is arguably the most important stage of sleep. Deep sleep bolsters the immune system. It's also involved in the slowing of metabolic processes, which allows the body's immune system to utilize a greater amount of energy to fight an infection. During an infection, we spend a greater amount of time in stage 3, not only because of the slowing of our metabolic processes, but also to accommodate shivering. Our bodies cannot shiver during REM stage due to muscle atonia. Thus, during an infection, REM sleep is almost non-existent. Any fragmentation of REM sleep we get during fevers usually leads to increased nightmares. This stage is also very important, allowing for growth. Evidence shows that our growth hormone concentration continues to increase during the first 4 hours of sleep. There is evidence that deep sleep contributes to insightful thinking, creativity, and memory. The stage lasts for 20 to 40 minutes. However, as sleep continues, these stages get shorter and more time gets spent in REM sleep instead. Stage 4 is also known as the REM stage. REM stands for rapid eye movement. During REM sleep, brain activity kicks up. REM sleep is also believed to be essential to cognitive functions like memory, learning, and creativity. Under normal circumstances, you don't enter a REM sleep state until you've been asleep for about 90 minutes. As the night goes on, REM stages get longer, especially in the second half of the night. During REM stage, in most adults, the electroencephalogram of the neocortex exhibits low voltage, while on the other hand, the hippocampus region regularly produces high theta waves. This is a picture of the electrical activity going on throughout all stages of sleep. The primary brain structure responsible for generating REM sleep is the brainstem, and more specifically, the pons and the adjacent portions of the midbrain. researchers discovered that the activity exhibited during REM sleep was unique. Subjects report to be vividly dreaming during stage 4. The electrical activity of the brain during the REM stage strangely mimics the electrical activity of the brain when the person is awake. This is referred to as paradoxical sleep. The biggest difference, however, is that the production of hormones like norepinephrine, serotonin, and histamine is completely blocked, causing the muscles to stop moving, also known as muscle atonia, which is why when we dream of flying or running through the woods, we don't really move. It's very important to also mention that just because a person may enter the REM stage doesn't necessarily mean that the person is dreaming. Children younger than 6 years who have larger amounts of REM sleep than adults do not typically report more dreaming. Narcolepsy. Narcolepsy is characterized by uncontrollable sleepiness and intermittent manifestations of REM sleep at times when a person would normally be awake. Besides sleepiness, the REM manifestations may include cataplexy, sleep paralysis, hypnagogic hallucinations, etc. Narcolepsy is not a common disease. It is idiopathic. The largest population study estimates the prevalence of narcolepsy at 26 per 100,000 people in Finland, which is similar to the prevalence of myasthenia gravis, Marfan syndrome, and Crohn's disease. The actual prevalence, however, is suspected to be higher, where in the United States, approximately 5% of patients seen at the AASM accredited sleep disorder centers have narcolepsy. Most narcoleptic patients experience cataplexy, a sudden loss of muscle tone with the same reflex suppression that is seen in REM sleep. High amplitude theta activity in the hippocampus, a characteristic of REM sleep, is also prominent in cataplexy. Further evidence for links between narcolepsy and REM sleep comes from studies of neuronal activity during cataplexy. Many of the same cell population in the pons and medulla are tonically active only during REM sleep in normal subjects strangely become active as well during cataplexy in narcoleptic patients. Most cases of human narcolepsy are caused by a loss of hypocretin neurons. Hypocretin neurons contribute to the regulation of the activity of norepinephrine, serotonin, histamine, acetylcholine, glutamate, and GABA cell groups. These transmitters have potent effects on alertness and motor control and are normally activated in relation to particular emotions. Hypocretin 1 is reduced in the cerebrospinal fluid in most people with narcolepsy. Neurons which contain hypocretins are widely found in the pons, thalamus, and the cerebral cortex. Recent findings indicate a reduction or full loss of hypocretin cell development in the lateral thalamus with people with narcolepsy. Unfortunately, there's really no gold standard for the diagnosis of narcolepsy. The disorder is often misdiagnosed on a clinical basis. A polysomnogram, PSG, is used for assessing nighttime sleep. And on the other hand, multiple sleep latency test, MSLT, is employed to evaluate daytime sleep attacks that last for a short period of time. I want to present you an interesting case of narcolepsy. VH is a 60-year-old male who was presented with EDS for the past 1 year. EDS is excessive daytime sleepiness. His EDS was characterized by sudden onset of sleepiness without any preceding tiredness. He fell asleep while reading the newspaper, working on the computer, watching TV, talking on the phone, and was even drowsy while driving. In order to stay awake, he started engaging in various activities like painting the walls at home, exercising, listening to loud music while driving. He started having cataplexy attacks 2 months prior to visiting the sleep clinic. The frequency of episodes varied depending on his emotional state and ranged between 5 a day to more than 15 in 5 minutes. These episodes commonly occurred while watching emotionally laden TV shows and were also triggered by sharing jokes, anger, unexpectedly meeting a relative, being the center of attention, or simply when excited. The cataplexy episodes lasted for 5 to 6 seconds on average, with a maximum duration of around 20 seconds. During such episodes, his face and shoulders drooped. He appeared emotionless and became immobile, with a sense of weakness in his legs. He could not resist a cataplexy attack once it started, but he learned to prevent it by simply just avoiding the emotional situations in the first place. He also reported visual hallucinations of seeing Snake while awaking from his sleep. Although it is important to note that he did not have any sleep paralysis. Although he did not have any difficulty initiating sleep, he woke up several times throughout the night. His past medical history included a few episodes of generalized seizures, each lasting for seconds. They were associated with fever at 8 years of age, which is suggestive of febrile seizures. He did not have any history of head injury, nor did he report any flu-like illness, immunizations, sleep apnea, or restless leg syndrome. He did not have any history of current or previous substance abuse and did not report any recent life stressors. He scored 24 out of 24 on the Epworth Sleepiness Scale, indicating very severe EDS. The overnight PSG showed a REM sleep latency of just 5.5 minutes compared to the normal 90 minutes, without any sleep apnea or periodic limb movement during sleep. The MSLP scores revealed severe daytime sleepiness with sleep onset REM periods in all 4 naps. A normal CT scan and MRI of his head ruled out any secondary causes of narcolepsy. An autoimmune workup, including HLA typing, was not done, as the diagnosis of the idiopathic narcolepsy with cataplexy was obvious from the history, MSLT, and neuroimaging results. He was initially put on modafinil 200 milligrams daily, and later was on armodafinil 250 milligrams daily, each for 4 weeks, however, without any improvement. Subsequently, he tried taking methylphenidate initially at 10 milligrams a day twice. This was later increased to 30 milligrams a day. Along with the prescriptions, scheduled napping was also recommended, but he was not able to follow up with it as he would sleep irresistibly at odd times and places. Although he did report an improvement in his EDS with methylphenidate, he still continued to have a substantial degree of daytime sleepiness, 3 hours after taking his dosage. It also presented side effects such as headaches, shaking, jittery, and fast speech. Therefore, doctors switched him to a long-acting stimulant, a combination of amphetamine and dextroamphetamine, also known as Adderall XR, which improved his EDS dramatically. The EDS was reduced to a brief scheduled nap after returning from work. He was able to stay alert, read a newspaper, watch TV, work on the computer, and drive without any difficulty. Although there was an initial improvement in his cataplexy episodes with these new stimulants, after a few months he still reported having these episodes. As a result, he was started on sodium oxybate, 2.25 grams at bedtime and 2.25 grams 4 hours later. This was gradually titrated to 7.5 grams a day, at which the patient reported more than a 90% decrease in his cataplexy attacks. The diagnosis of narcolepsy with cataplexy was established based on the EDS, frequent cataplexy, hypnopompic hallucinations, short REM latency during an overnight PSG, and short mean sleep onset latency. In this case, the age at onset of symptoms of narcolepsy with cataplexy was 60 years. It's important to note that narcolepsy with cataplexy with age at onset after 40 years is uncommon. This report presents a classical case of narcolepsy, but late age of onset and severe symptoms, including severe daytime sleepiness and frequent cataplexy attacks. He would fall asleep more than 50 times in the daytime. The doctors considered a possible neurological cause for late age of onset and severe symptoms. However, imaging studies, including CT and MRI scans of the brain, were both normal. In this case, the patient did not have any response with FDA-approved first-line agents, including modafinil or armodafinil, and only had a short-lasting response with methylphenidate. But as previously stated, it did improve. There was substantial improvement, in his daytime sleepiness with amphetamine and dextroamphetamine. The cataplexy episodes decreased substantially with the use of sodium oxybate. This suggests the possibility that in narcoleptic patients with late age of onset, first-line FDA-approved agents like modafinil and armodafinil, as previously mentioned, may not show a good response, and that one should consider other medications, including stimulants, as previously mentioned, and sodium oxybate. Currently, there's a small number of evidences relating to MRS and SPECT findings in narcolepsy. The routine MRI, usually performed on patients with narcolepsy, shows particular differences in various parts of the brain and in the pons region. Furthermore, according to many cerebral perfusion studies, various perfusions in the hippocampus, frontal premotor cortex, pons, and thalamus were detected. A study published on Intecopen explored the relationship of clinical and laboratory tests with the results of imaging tests. The researchers tried finding out the role of MRI, MRS, and SPECT examination, determining the structural changes in the cerebrum and the brainstem of people with narcolepsy. Once imaging was done, the routine MR and MRS data was analyzed by a radiologist. Values of N-acetyl aspartate, NAA, choline, CHO, and creatine, CR, and the respective ratios were also obtained. Routine cranial MRI for all cases involved showed no pathological signal variation. As presented in front of you, these are sagittal flare and coronal T2W images, respectively, normal cranial MRI images in patients with narcolepsy from the study. In the MRS examination, from the frontal cortex and thalamus, there was no significant statistical difference between NAA to creatine, NAA to choline, and choline to creatine ratios of people with narcolepsy and compared to that of the control group. Measurements from the pons and hippocampus, however, indicated that NAA to choline ratios for the narcolepsy group were significantly lower compared to that of the control group. On the other hand, choline to creatine ratio at the pons region for narcoleptic patients were higher than that of the control cases. In terms of pontine NAA to creatine values, there was no significant difference detected. In the study, SPECT examinations, the parietal lobe showed hypoperfusion for one case. SPECT examinations, however, for other cases were evaluated as normal. This is the image of the hypoperfusion of the parietal lobe. The brain perfusion SPECT gives information regarding blood buildup in various anatomical regions of the brain. Reduced activity in hypothalamus, thalamus, prefrontal cortex, parahippocampal gyrus, hippocampus localizations was found during SPECT examinations. According to the study, in 9 of the 10 cases with diagnosed narcolepsy, no perfusion change was detected during SPECT examinations. Only one patient showed hypoperfusion in the right cerebral hemisphere parietal lobe, as presented in front of you. Based on these findings, it may be suggested that SPECT examination has limited contribution to the evaluation of the cases with diagnosed narcolepsy. In another cerebral SPECT study of over 25 patients with narcolepsy suggested that hypoperfusions had been found in the parahippocampal gyrus, hippocampus, frontal cortex, as well as the pons and the thalamus. These regions probably reflect the cerebral hypocretin system. In consideration of the fact that narcolepsy may be attributed to neuronal loss or damage in the hypothalamus, MRS examinations were performed in relation to hippocampuses for people with narcolepsy. In these studies, involving a limited number of cases, hypothalamic NAA creatine ratio was found lower in patients with narcolepsy compared to the control group. Based on this finding, it was emphasized in the study that the central pathology in narcolepsy might be the neuronal loss of the hippocampus. In the cranial MRI examination on patients with diagnosed narcolepsy, the study detected no significant variation in signal intensity in the PONS stage or a pathological finding. The findings in this report makes us think that routine MRI examinations on patients with diagnosed narcolepsy the MRI has no considerable contribution to the diagnosis of narcolepsy. It is, however, the MRI, however, may contribute to the exclusion of other organic lesions, restricting developmental diagnosis. As a result, MRI and SPECT examinations have limited contribution to the diagnosis of narcolepsy. MRS, on the other hand, appears to be more beneficial in diagnosing narcolepsy, indicating those structural changes that cannot be detected through the routine cranial MRI. REM sleep behavior disorder, RBD. It's fundamentally characterized by sleep without atonia, dream enactment behavior, and sleep-related injury to others. As the atonia, which occurs normally in REM sleep, is absent in RBD, the patient exhibits complex motor behavior in response to dream mentations. Its clinical features include uncharacteristic abnormal vocalizations, such as grunting, shouting, screaming, swearing, etc. It also includes abnormal motor behavior in the form of running, jumping, punching, flailing, kicking, and altered dream mentations, which generally consist of insects or animals or bellicose strangers chasing the dreaming person. Unlike in normal dreams, the patient retains memory of the vivid dreams for months or years on end. I want to present two cases that particularly caught my attention. Case 1, a doctor aged 68 years present with history of violent dreams for more than 50 years and had some strange happenings over these years. Anamnesis brought out that he started having vivid dreams of wild animals attacking him at just 9 years of age. On one night, he attacked a person sleeping beside him with a stout stick when he dreamed of an animal attacking him. No further violent episodes occurred until much later. When he was 11, he witnessed a murderous assault on his father and developed symptoms of post-traumatic stress disorder, PTSD. Vivid dreams continued along with trauma-related dreams and memories. He would shout and scream at night once in a month or so, but exhibited no violence. At about 17, he developed sleep attacks and after a year had a single episode of sleep paralysis associated with visual and haptic hypnagogic hallucinations. The sleep attacks resolved spontaneously after his marriage at 22. After many years, he consulted a psychiatrist for his PTSD symptoms and recovered with treatment, but overly aggressive vivid dreams continued. Now he would make elaborate plans of defense while actively dreaming. On one night, he clobbered his brother when he saw a wild animal attacking him in his dream. His wild screams woke up others and further damage was averted, thankfully. He continues to get vivid, violent dreams, but while dreaming, he now knows that he is dreaming and learned to dismiss them. He continues to live an active life running his business practice. Physical examination and mental status examination revealed no abnormality. He could recall all his dreams in great detail. He was satisfied with the knowledge that he had a sleep disorder and declined to get investigated or to take treatment. Case 2. A 64-year-old male sought psychiatrist consultation after excessive dreams and violent behavior during dreams of a 2-year duration. Onset was sudden while on a train journey. He dreamt of thieves entering into his compartment. Screaming loudly, he attacked other passengers. Well-meaning fellow travelers intervened to de-escalate the situation. Since then, he experienced vivid dreams in profusion at night nearly every day. In the dreams, he would invariably be under attack from strangers. In an effort to drive them away, he would let out wild screams and throw punches, which unfortunately would land on his wife. Family members thought he was under the influence of an evil spirit at night, since he would be his usual docile self during the day. Exorcism brought him no relief. Some of his friends volunteered to sleep by his side for some time, but retreated after repeated hits. His wife, unfortunately, bore his repeated assaults stoically until one day he delivered powerful blows to her face, dislodging 4 of her front teeth. He felt ashamed and left the house and came for consultation on a friend's suggestion. He worked well as a mechanic until his retirement 2 years before. After retirement, he remained active doing social work and in his housing society. He was a teletailer and had no medical illness or fits. Physical examination revealed no abnormality clinically. Mental status examination revealed a well-groomed person who talks fluently. Cognitive functions were intact. He could recall all his dreams in great detail with appropriate expression of feelings. Hematological parameters, biochemical parameters were all within normal range. Awake EEG showed no seizure activity. He declined to undergo a PSG as he thought it was not necessary. An MRI of the brain also revealed no abnormality. Response to the treatment with clonazepam 1 mg and melatonin 3 mg at night was very effective. By the end of the second week, he was free from all violent dreams and reported normal dreams in which he could not recall them. At a 1-year follow-up, he continues to remain asymptomatic. The exact cause of REM behavior disorder, or BD, is unknown, although the disorder may occur in association with various degenerative neurological conditions like Parkinson's disease, multisystem atrophy, and diffuse Lewy body dementia. Studies have tried to determine structural MRI digital microscopic characteristics of REM sleep behavior disorder in individuals with low, intermediate, and high likelihood dementia with Lewy bodies, DLB, at autopsies. In several autopsy series, more than half of the patients with Lewy body pathology simultaneously had Alzheimer's pathology. Both Alzheimer and Lewy-related cerebral pathologies are characterized by the early involvement of the limbic structures, specifically the enterohinal cortex, amygdala, and hippocampus. Preserved hippocampal volumes measured on the antemortem MRI have been shown to be associated with high likelihood DLB. On the other hand, hippocampal atrophy was associated with low and intermediate likelihood DLB. Of the 75 patients studied, 47% were RBD positive. Those classified as RBD positive were younger and were more likely to be male. Given the age and sex differences between the RBD groups, as well as the differences in the MRI death intervals, all further analysis were adjusted for these covariates. This table shows that 85% of RBD negative patients carried an ante-mortem clinical diagnosis of Alzheimer's or mild cognitive impairment, MCI, and 80% had a low likelihood of clinical DLB syndrome based on neuropathology. In contrast, 89% of the BRD positive patients carried ante-mortem clinical diagnosis of DLB or MCI, and 94% had an intermediate or high likelihood DLB neuropathology. 82% of RBD positive patients had diffuse cortical Lewy body pathology compared with the RBD negative patients. 34% of the RBD positive patients had a neuropathological diagnosis of Alzheimer's compared with RBD negative patients. Fluctuations, Parkinsonism, and visual hallucinations were more frequent in RBD positive patients. BRAC NFT stage was higher in RBD negative patients and indicative of NFT pathology in the limbic system as well as association cortices, whereas RBD positive patients had lower BRAC NFT stage, indicative of NFT pathology, more restrictive to limbic regions. Figure A is a three-dimensional surface render map, while Figure B is an overlay from the custom template. Both demonstrated greater atrophy in the posterior cingulate, precuneus, lateral, parietal, and posterior temporal cortex, hippocampus, and amygdala in the RBD negative compared with RBD positive patients. The posterior cingulate and precuneus atrophy appeared to be symmetric, but upon closer examinations of the hippocampus and amygdala revealed that atrophy in the mid-sagittal sections of the surface render maps and the coronal section from the custom template demonstrated asymmetric left greater than right atrophy. The inferior view from the maps demonstrated a more pronounced uncal atrophy in the left, which is demonstrated in the sagittal view from the custom template. Consistent with the literature, RBD positive patients were more often male and had a younger age of death. Not surprisingly as well is that despite the presence of neurobody pathology, the majority of patients in the low likelihood DLB group met criteria for a clinical diagnosis of dementia with Alzheimer's. Patients who were RBD positive had less Alzheimer-related pathology, greater frequency of diffuse Lewy body disease, and lower degree of atrophy on MRI compared with those who were RBD negative. RBD was present in 21 patients with high likelihood, 12 patients with intermediate likelihood, and 2 patients with low likelihood. Patients with RBD had a more frequent neuropathological diagnosis of diffuse Lewy body disease. Patients without RBD had greater atrophy of the temporoparietal cortices, hippocampus, and amygdala than those with RBD. Atrophy of the hippocampus and amygdala were associated with greater phospho-tau burdens in these regions. In conclusion, the presence of RBD is associated with a higher likelihood of DLB and had less severe Alzheimer-related pathology in the medial temporal lobes, whereas the absence of RBD is characterized by Alzheimer-like atrophy patterns on MRI and increased phospho-tau burden. Dreams and psychosis. Dreams have often served as a model for psychosis. Visual, auditory, kinetic, tactile hallucinations, bizarre ideas, incoherence of thoughts, fears, terrors, and emotional chaos often characterize our dreams, as they also characterize the experience of schizophrenia. Both psychotic patients and dreamers accept impossible events as being real and don't realize their own imagination is generating these fantasy events at the time of dreaming or psychosis. As you all know, this is clinically referred to as a lack of insight. Dreams of individuals with schizophrenia have been characterized as anxious, hostile, grandiose, containing themes of threat and foreboding. In a study comparing the dreams of 20 patients with a schizophrenia diagnosis to patients with other diagnoses and to community controls, it found that the dreams of the schizophrenia group were impoverished and lacking in emotional expression. In a response to a recent online survey of over 100 clinicians treating schizophrenia, disturbed sleep was reported as a symptom of their patients. They also endorsed the statement that sleep and psychotic experiences exacerbated one another. Among the parasomnias, it is the frequency of nightmares in childhood that best predict psychosis in adolescence. Nightmares have also been reported to predict schizophrenia relapse. In a 1998 case study of a 40-year-old woman with schizophrenia, the authors described two psychotic relapses in the same patient, both immediately preceded by intense and vivid nightmare attacks. Patients with schizophrenia had a substantially higher rate of nightmares. Although other research has found association between psychotic symptoms and nightmare frequency, neither positive symptoms like delusions and hallucinations nor negative symptoms like asociality and apathy appear to have a strong influence on nightmare rates. The investigators and others concluded that nightmares did not really mirror symptoms, but rather reflected the degree of distress shown by schizophrenia patients. So, does treatment of nightmares diminish psychotic symptoms? There are a number of effective treatments for nightmares, such as drug treatment, specific forms of cognitive behavioral therapy, notably imagery rehearsal, prescription therapy, exposure and systemic desensitization, and lucid dream therapy. Imagery rehearsal therapy, IRT, is the most frequently used therapy and focuses more on nightmares that tend to be recurrent. The patient is helped to transform their content and to repeatedly rehearse the transformations. While lucid dreaming therapy is an interesting and a relatively novel treatment for nightmares, lucid dreams are dreams in which a person becomes aware that he or she is dreaming and is able to make a conscious decision to change the direction that the dream is taking. Individuals can be trained to be lucid dreamers, to become aware in the midst of a dream of the fact that they are indeed dreaming. This insight gained is credited for reducing the distress of nightmares. It has been hoped that insight training that works for nightmares could work in the same way for insight defects associated with schizophrenia, but this has not been proven to be effective until now. Psychological treatments for nightmares appear to work through the provision of an increased sense of mastery, a reduction of fear, a restoration of sleep, and the removal of counterproductive beliefs. In principle, these mechanisms should be able to exert positive effects on the symptoms of schizophrenia. But in a small study by Sheaves, a reduction of nightmares, a reduction of nightmare following IRT did not diminish psychotic symptoms, although participants did describe a positive change in their emotions. There is evidence that improvement in nightmares can improve well-being and reduce general psychopathology in diverse groups of psychiatric patients, including those with schizophrenia. and that brief psychological interventions that improve sleep are seen as important and very much appreciated by this population. Precisely because of this appreciation, we can never really dismiss the operation of a placebo effect in the reports of well-being. Prescribed drugs used in various diseases, in various disease states, can alter sleeping patterns and leading to dreams affecting one or other neurotransmitters. Drugs influencing adrenergic, aminergic, dopaminergic, and cholinergic neurotransmitters have a prominent role on dreams and nightmares. These neurotransmitters may function by modulation of the REM and non-REM sleep stages. Antihypersensitive agents in general use affect adrenergic receptors. They are known to be non-REM suppressants. These drugs have been shown to affect REM sleep and thus cause dreams. Decrease in dream recall occurs with the use of both REM suppressants and non-REM suppressants. Drugs used in Alzheimer's disease. REM sleep is affected by pharmacological alteration of the cholinergic activity in the CNS. Many lines of study support the hypothesis that brainstem cholinergic neurons can be excited to induce REM sleep. Anticholinesterases such as donepezil and tacrine are likely to increase the percentage of REM sleep, while cholinergic antagonists have a tendency to decrease REM sleep. Anticholinesterases affecting acetylcholine neuron receptor system thus have a possible association with drug-induced nightmares. There are many drugs such as opium, cocaine, cannabis, coal tar products, and alcohol, which have an abuse potential and may as well have an influence upon our dreams. Dreams caused by such drugs are, however, influenced by the physiological action of the drug taken, the amount, the idiosyncrasies of the individual, and the mentality. Drugs such as opium and cocaine, when taken in medicinal doses, produce a sense of well-being and comfort, and so tend to promote pleasurable fancies. These drugs, however, when taken in sufficient doses, cause sleep dreams which are not remembered. Many people are distressed by these drugs, and others, in place of awaking refreshed or awake tired and dimly conscious of disturbing dreams. CNS stimulant drugs like amphetamines and caffeine may lead to dreams as well. Amphetamines are associated with vivid and unpleasant dreams, whereas caffeine has been used to induce lucid dreaming because it makes one sleep lighter. Dreams are thus, according to many, reflections of the subconscious mind and are caused by a variety of pharmacological agents. These agents act via a variety of neurotransmitters: adrenergic, cholinergic, dopaminergic, serotonergic, and GABAminergic. These drugs are either pharmacotherapeutic drugs prescribed for treatment of various diseases or are the drugs of abuse. These drugs may be responsible for the causation of dreams, which are either pleasant in nature or maybe in the form of nightmares. Finally, I want to conclude this presentation by saying various disorders, lesions, traumatic events, and prescribed drugs have huge effects on our sleep, our capability of dreaming, and what we dream of. It's quite challenging to study dreams because they take place entirely in the mind of someone who is unable to communicate in the moment. We don't really have the tools that help us observe the dreams directly, at least not yet. And while many scientists are on the frontier of helping us record our dreams through machines and through machines and algorithms, the data is not yet reliable enough to draw any definitive conclusions. uh, dreams impact the quality of our sleep, how our brain learns and retains information. A good quality sleep can boost our immune system and accommodate healing. Tools are constantly being developed to help us understand our brain even further. I very much look forward to the future where sleep related disorders are not as idiopathic as some of them seem at the moment. So, as an ending, let's keep dreaming for a brighter future. And I thank you all for listening.
No, pues,
Right.
muchísimas
Thank you very
gracias,
much, Dr. Ahmad Assassa. Would you mind if I ask you a few questions?
Of course.
So, lucid dreaming is something that's actually quite interesting to me. But you talked about the therapeutic use of lucid dreaming. So, what exactly is the lucid dreaming therapy, and is it actually useful?
Basically, it depends on lucid dreaming, which I explained, where you're aware of your consciousness. You know, it's a form of metacognition or awareness. Often, lucid dreaming also lets you control what happens in your dreams. It may be useful in treating conditions like PTSD, recurring nightmares, and anxiety. Lucid dreaming usually happens spontaneously. However, you know, through practice, it's possible to be able to master it. Um, it, this is what it is. It is very, it's an, it's a very novel idea. There's still a lot of research going into it and a lot of data and studies, but so far the evidences for many of it sounds promising.
Oh, I see. On the topic of dreams, what's your opinion on them? You know, that they use their effects, you know, on the greater on the mind, on the development of any of all these disorders.
Well, for me personally, dreams are a reflection of our subconscious mind. You know, they reflect the feeling that we feel internally, but might be too afraid to say it due to societal norms. You know, obviously not all dreams make sense, but you know, if like one day you're fighting off a couple of animals and the next second you're drinking tea with Abraham Lincoln, you know, this is obviously doesn't make sense, but sometimes it's just uh, for some stuff it does make sense. You know, it's how the brain might be able to retain the information, you know, it took throughout the day. So I don't believe that it has this majestic or spiritual association that many, quite frankly, associate with it.
I see. Thank you. And the final question, you mentioned RDB, but in relation to neurodegenerative diseases, does it always cause Alzheimer's or Parkinson's, or is there still other things
Well,
that cause it or affect it?
Well, basically, so RBD is very idiopathic. So we don't really know how it happens or the causes of it, but it does not cause it. However, it is strongly associated with it. You know, usually when we find Alzheimer, there's a high percentage that the patient also experiences RBD. Um, I've mentioned in these statistics in the table that a lot, you know, I forgot the statistics, but around, I want to say 80% were um, people who had RBD also had Alzheimer's and Parkinson's and other neurological diseases. So it does not cause it, rather it's strongly associated with it.
Oh, I see. Thank you very much for your time, Dr. Ahmad Assassa.
Of course.
I
Thank
believe
you,
that
Dr.
concludes
Christopher
our
and Dr.
meeting.
Lewis.
See, and thank you very much, doctor. Your presentation was wonderful and really interesting. So thank you for your time, for all your work.